Hello, dear colleagues, attendees, panelists. I'm welcoming you to a new session in the Mega Online course. Today is the Fluid Stewardship Debate Symposium. We have a couple of interesting lectures and then a debate afterwards. First, we're having a lecture on balanced fluids in the intensive care. This lecture is presented by Dr. Neeraj Kumar. He is an assistant professor, trauma and emergency in Panta, India. This lecture is going to be moderated by Professor Dr. Ahmed Madi, who is an ICU consultant and director of critical care and training internship programs, King Saudi Medical City, Riyadh, Saudi Arabia.
Now, I'd like to present our debater of this session, Dr. Muhammad Khan. Dr. Muhammad Khan, you have a lot of audience with you. Most of the 70% of the audience are using normal saline. He's associate professor, of course, of critical care medicine, trauma center and central emergency, Rajendra Institution for Medical Science. Dr. Muhammad Khan is a fan of the normal saline. Unfortunately, Dr. Kumar, you have only 20% supporting you. Let us see after your debate. Okay? Welcome my debaters, Prof. Khan and Prof. Kumar. We can start your presentation. Try to convince them, please.
Thank you so much, Professor Saad and Ranajit sir, for
I will stop my share and you can share your screen, Prof. Okay?
Yeah. Thank you so much, Professor Saad and Ranajit sir, for inviting me on this August panelist group. And I'm sure that I will be able to do justice with quoting some of the good references and evidence-based trials that balanced salt solution why couldn't be used as a fluid resuscitation. So I'm just going to share my screen and just need 1 second. Now I will going to discuss on balanced salt solution. And so my warm greeting from AIMS Patna. And I have no disclosures and no conflict of interest. So the outline of presentation will be like that. I will talk few things about history, gamble concept, what's wrong with 0.9% normal saline, what is the concept of your hyperchloremic metabolic acidosis and which is ideal resuscitation fluid, why balanced salt solution, what is ideal crystalloids, and what are the clinical trials that are associated with it. Few points about basics plus split, smart, and salted trials, and some role of BSS in trauma and surgery, and then few points about calcium-free balanced salt solution in RRT. So the first is we should not forget this scientist, the hot dog hamburger, because he is the first who has done these coined the term normal saline, and he suggested that the human blood has a concentration of 0.9% normal saline than 0.6 actual concentration of 0.6. Later on, Sidney Ringer is an Australian physician who coined the term Ringer lactate because he has introduced sodium chloride solution by putting some potassium and calcium to promote contraction. Then after that, Alex Hartman, we'll not forget Alex Hartman because he was the first who added non-chloride anion lactate to prevent metabolic acidosis, and this solution was popularly known as Hartman's solution or lactate Ringer solution. Later on, the Gamble's diagram you see, already we have discussed lots of things about the different constituents of crystalloids, but my highlighting facts will be on the chloride concentration. You see the chloride concentration of the plasma that is closer to 100, and now our target is to decrease that chloride concentration to 75%, which is present in new formulation like balanced salt solution, because it has an acetate and a chloride which is closer to 100, or with a salt crystalloids, if acetate will be more in a tune of 50 millimoles, the chloride concentration would be around 75. So our target is to decrease the concentration of chloride. So why? So what's wrong with this normal saline? We all know that this normal saline is potentially more hypertonic. It is more supraphysiological. It has more supraphysiological chloride levels that lead to hyperchloremic metabolic acidosis. So what it will do basically, if you have a more chloride in the extracellular fluid, it will dissociate more water into H plus and OH ions, and these H plus ion will go into the intracellular space, causing more acidosis. So does it really matters? Yes, it matters, because this is the main drastic contrast features that what balanced salt solution doesn't have, because these balanced salt crystalloids have lesser potassium content and it is easily diluted in extracellular compartment. These salt doesn't mobilize potassium from intercellular space, and these have lesser chances of having common AKIs. Now you see that the clinical effect of hyperchloremic acidosis, you see that there are might be the presence of persistent acidosis. Maybe this patient have a oliguria, abdominal discomfort, nausea, and some decreased mental capacity, which is not always associated with BSS, that is balanced salt solution. Now, there are few deleterious effect of these high chloride content. I will not go in details, but just read few of them: that AKI risk, hyperkalemia risk, increased endothelial surface damage, increased pro-inflammatory mediator release, more gastrointestinal perfusion and function will be detrimental, and more effect on coagulation cascade. And then the role of these balanced crystalloid. Already Professor Saad has this pointed these few lines already, because they are an optimal choice of fluid for critically ill patients for resuscitation, but it is still controversial. But most of these patients are receiving 0.9% sodium chloride. So preclinical and early clinical evaluation have raised several questions. So why so? Because these normal salines resuscitation have macrocirculatory and microcirculatory adverse effects like AKI, like renal vasoconstriction, like hypercholemic metabolic acidosis. What it will do? It will increase the mortality. So on compared with normal saline with balanced salt solution, it is more effective, have lesser adverse effect, and modest cost difference. Now, coming to the ideal resuscitation fluid, what are the characteristics? First, you see that these have mostly, these can increase the intravascular volume. They have a composition closer to ECF. They have rapidly metabolized to the tissue, so no tissue storage should be there. And they do not produce adverse metabolic or systemic effects, no hematological or immunomodulating effect, and cost effective. And last, the longest shelf life. So this is important. Now the concept of strong ion difference, where I will just highlight that what is this SID. So suppose if you subtract all cations from anions, you'll get SID. So what does it mean? If a solution have more chloride ions in it, it means it has a lower SID of a value less than 40. So it will denotes more acidosis. So suppose on decreasing the chloride, the SID will increase, which will denotes the alkalosis, which is acceptable for the human body, but acidosis is not acceptable. So the concept of SID is very important. Why this balanced salt solution? Because it's a physiologically more similar to plasma. It achieves the acid-base balance with bicarbonate. It has infusion of bike solution. BSS is devoid of fluid or potential overload. So ideal crystalloid solution, I will not go in details. We have already discussed. And so there are concept of acetate and lactate buffer. So why this is important? Because you see that if a solution is having an acetate, it is metabolized to bicarbonate within 15 minutes. But if a solution is lactate, it is metabolized, it takes around 60 minutes to convert to bicarbonate. So what is the advantage? Advantage is that you can't measure the tissue hypoxia if the lactate level is very high. And although few drawbacks are with acetate, only that it cannot be measured. But the important thing is that it can be a marker of tissue hypoxia. Means lactate basically will hamper the measurement of tissue hypoxia. Why so? Because we all are aware that the advantages is that it is more isotonic. These are metabolized basically by extrahepatic route, and the lactate has a poor marker of hypoxia. And then unlike lactate, it has no effect on glucose metabolism. So surviving sepsis guidelines 2021 tells that your measuring your blood lactate is very important, although weak recommendation and low quality of evidence. So we want to use a solution with more acetate than lactate. Now coming to the I will not go in details because this study has compared the balanced salt solution with or without lactate. So here it's suggesting that the plasma light group have a lesser lactate concentration, and that's why it is more useful even in living donor patient undergoing right hepatectomy. Now coming to the normal saline versus balanced solution healthy volunteers. What does this study show? It was again a study from Nottingham University, and what it shows, it was a randomized controlled double-blind trial. It suggested that the patient who are receiving this 2 liters of normal this balanced salt solution have a more reduction on receiving 0.9% saline, more reduction in renal blood flow and renal cortical perfusion than patient receiving balanced salt solution. And then a systematic review on resuscitation guidelines for severe sepsis was published, and it was again suggestive that balanced crystalloid in sepsis can be linked directly with lower mortality. Now coming to the fluid of choice about the severe sepsis as well, few models like in 2017 also crystalloids has been more commonly used for sepsis resuscitation, where balanced solution was preferred to normal saline and colloids. Coming to the evidence-based clinical trials, the first very important meta-analysis on fluid resuscitation in sepsis was published in Annals of Medicine, and it suggested that that 18,916 patients were included, where they suggested that the resuscitation with balanced crystalloids or albumin seems to associated with reduced mortality. Later on, again a very big systematic reviews and meta-analysis was published and it was the largest one where it was suggested that it has that low versus high chloride content have a better even the chloride content, a lower chloride content was having a better outcome than comparing with a higher chloride content solutions. Coming to the even in pediatric septic shock, the balanced salt solution is now is telling that this balanced salt solution have balanced salt solution receiving groups of patients have a higher survival, and these patients have a strong SID on a lower values and comparing with a normal saline solution. A basics randomized control trial was published in JAMA in 2021. It is also suggestive that they have compared with 0.9% normal saline, and they found that the mortality in BSS group was very less, 26.4 in comparing with 27.2%, although 10,000 patients were included for the ICUs. And later on, the concept of your tubular glomerular feedback was there. Why I'm discussing is here again the role of concentration, high chloride concentration, because if a high chloride concentration will be there, the high macula densa will sense that high chloride content, and it will trigger the afferent vasoconstriction, which will lead to decrease in GFR and impaired renal function. So based on that, the chloride ion concentration was very debatable, and it was not being used, and balanced salt solution were given the priority. Even the latest guidelines of the surviving sepsis has been suggested either using balanced crystalloid solution for resuscitation, although the recommendation was weak. Later on, the plus randomized control trial was published in 2016, and it was done in Australia, where they have compared the plasma light with saline study. And what they found that these plasma light plays a vital role on estimating the comparative risk versus benefit, and they found that the plasma light was providing more benefit to the patients rather than comparing with this normal saline. Then a split randomized control trial was published in 2015, and what it suggested, it was again compared the buffered crystalloid solution with saline on AKI patients in intensive care unit. What they found, they have done these trials on 2,278 eligible patients, and what they found that the patient who have received the balanced crystalloid solution have a lesser need of having those RRT in comparing with the patient who was on saline. So they finally concluded that these patients on receiving crystalloid therapy in the ICU do not risk of the AKI on comparing with the saline. Later on, the SMART randomized control unblinded trial that was again in 2018
Kumar,
published
please,
in
you have 2 minutes more, please.
Yeah, it was suggested that this solution having a major adverse renal effect event. And what does this trial shows? That the major kidney events was more in the patient receiving in the saline group rather than on balanced salt solution group. And they compared the incidence of the MAKE, that is major acute kidney events, and they found that the MAKE was more in cases of patients receiving the normal saline group. So they concluded in critically ill patient that the saline patient receiving balanced salt solution can have a reduced incidence of death. Later on, this is a very comparative study in for that SMART trial. Later on, the salted trial published, and the salted trial included 13,000 patients. What it suggested? It suggested that the patient, see, that it suggested that these patients have equal hospital-free days, but the patients have lesser incidence of major adverse kidney events in a tune of around 4.7% in balanced group of solution, and in saline it was 5.6. So again, even in sepsis in 2014, they have given the use of these balanced salt solution on 53,448 patients. These are the largest, where they suggested that the mortality was progressively lower. And even these current surviving sepsis guidelines also suggested that the balanced crystalloid solution can be used instead of normal saline solution. Later on, again, even they have done these study on acute kidney injury in critically ill patient, and they suggested that the role of balanced crystalloid solutions were more having lesser mortality than patient receiving those normal saline groups. So similarly, there are a few other studies also on a contrast-induced acute kidney injuries patient, and they also suggested that they were done the first study in which they used the balanced salt solution in contrast-induced AKI patients, and suggested that it is a safer to use BSS in these groups of patients also. Even the few points about trauma, you will see that initial assistation of trauma patient, they conducted that the balanced salt solution have found that baseline pH and base excess were more maintained in the patient receiving balanced salt solution than saline groups of patient. So even the few trials related to traumas also suggested that the mortality was very less in the patient receiving the balanced salt solution. And coming to the last part, that is in renal transplant group of patient, again they have suggested that these patients on using the balanced salt and normal saline solution, in the normal saline group of patient, you see that the chloride level was very much high in comparing with the plasma light solution, and the length of stay was also very higher in the patient receiving the saline solution. So they concluded the metabolic profile was best maintained. Now, on the few points only about this perioperative calcium free, again, it has a benefit because they have given the study that the need of RRT was very, very much lesser in the patient receiving plasma light solution than patient receiving normal saline solution. So finally, my take home point will be large volume of saline is associated with more hyperchloremic metabolic acidosis. Balanced fluid cut down the risk of hyperchloremic metabolic acidosis. Acidated buffered balanced crystalloid can have added some advantages in diabetic patients, and SMART and salted trial already have strong evidence about the clinical advantages of balanced crystalloids in critical ill as well as non-critical ill patient compared to 0.9% normal saline. Thank you so much.
Thank you, Dr. Kumar, so much. And he actually take almost 3 minutes more your time, so I will compensate Dr. Saif Khan for these 3 minutes more. I think you try to convince us with the balanced saline, but even though, as you saw earlier, most of the audience, 70% is still using a normal saline rather than balanced solutions. So the difficult, I think, mission to convince us with the balanced, with evidence, with physiological, with the pathological changes behind the normal saline. I agree with that. Let us see our second debater, Dr. Mohammed Saif, Associate Professor of Critical Care Medicines. He's lucky because all the audience with him. So I think it would be easy mission for you, Prof. Dr. Mohammed, Dr. Khan. So let us have your opinion about you are supporting normal saline, which is mostly common use nowadays. Welcome, Dr. Khan.
Thank you. Thank you so much. Thank you so much, Professor Ahmed, for giving me the opportunity. I'm so grateful to the organizers. Are you able to see my slide?
Yes, very well. Thank you.
Yes. Yes. And my voice is clear?
Yes, yes, good. Very
yes?
Good.
Okay. So again, I'm so grateful to the organizers of online anesthesiology course And I have been given this task to prove that saline is superior to the balanced crystalloid in this debate. This is not going to be difficult for me to prove two things. The first one is that NS is equivalent to the BSS for fluid resuscitation with respect to mortality and renal outcome. And the second statement which I'm going to make over here is that NS is actually better than BSS for fluid resuscitation with respect to cost, availability, and the reactivity. So these two statements I'm going to prove in my next 10 minutes which have been provided to me. So claim of negative impacts of chloride load on kidneys is physiological only. Excessive chloride definitely induces renal vasoconstriction and reduces the GFR, which has been proven in animal models and few observational studies as well. However, negative impact of chloride load on clinical endpoints has not been consistently observed in many RCTs published to date, which I'm going to show you. The maximum change in chloride level in patients receiving large amount of saline was only 3 millimole per liter according to the latest large trial called PLUS study published recently in Jan 2022. There has been concern that large volume of normal saline can lead to non-gap metabolic acidosis, which actually is true, but it's not very concerning. This concern is unnecessary because humans can tolerate rather a significant acidosis for a short time if it is acutely developing. For example, permissive hypercapnia in ARDS patient can reduce arterial blood pH to 7.23 without affecting organ function and mortality. We all know that. Acidosis enhances the unloading of oxygen into tissues to meet the oxygen demand to the tissue. We all know that. It shifts the oxygen hemoglobin dissociation curve to the right. And now, there are firm evidences to show that NS is equivalent, if not superior, to BSS. So my dear colleague, Dr. Neeraj, have already mentioned few of the trials, and this is just a snapshot which I'm going to present here. Now, among all these major trials conducted in last 7 years, 4 major trials, including the recent one in 2022, have shown that normal saline can enjoy the place in the shelf of nursing stores. BSS is clearly not superior to NS in terms of 90-day mortality and also incidence of AKI. Only 2 trials, one performed in emergency department and another one, a single center, showed some supportive evidence in favor of BSS. But you can see here that much of evidence is not in favor of BSS. The PLUS study is the latest in the list of trials on BSS versus normal saline. This was a multicentric RCT conducted in about 50 ICUs in Australia and New Zealand, enrolling more than 5,000 ICU patients requiring fluid resuscitation. It did not show any significant difference in 90-day mortality and adverse renal outcomes. Now, this is the list of major meta-analysis performed in last 4 years, including plethora of patients from all major trials, and all showed only one thing: the similarity between BSS and NS, and concluded that NS should not be victimized for its salinity, for its high chloride content. For example, this meta-analysis by Dong showed no significant differences between balanced crystalloid and saline in terms of mortality if you look at the position of diamond in this beautiful forest plot. The subgroup analysis of this same meta-analysis showed that TBI patient NS is superior in terms of mortality. Another recent meta-analysis by Hammond, published in NEJM Evidence, showed similar 90-day mortality, AKI, and need for RRT. Look at the diamond. And a 2019 meta-analysis by Chow, including 9 RCTs, failed to show any significant differences in mortality again. In this meta-analysis, there was no significant differences in the incidence of AKI2. The current estimated cost of plasma light and lactated ringer is about $4.5 compared to $2 per liter for the saline. Now you can yourself see that why do we use normal saline so widely. Normal saline is the oldest fluid which we are using widely since last 2 centuries. We have extensive experience with its use. The infusion of ringer's lactate may cause elevations in the serum lactate, which has been clearly mentioned by my colleague, Dr. Neeraj. And this level may be exaggerated in the liver failure and in patient with septic shock. And you know that lactate monitoring is crucial in guiding fluid management in septic shock patients. So giving RL in such patient is not appropriate as we lose an important clinical monitoring at bedside. Moreover, acetate and gluconate in the plasma light is said to increase the sugar level. Normal saline is used as a vehicle for administration of various drugs. Normal saline is favored diluent for various antibiotics due to its greater compatibility. However, the drug shown to be the plasma light is shown to be incompatible with the midazolam, and there are few drugs which are incompatible with the RL2, such as ciproflox, diazepam, phenytoin, and propofol, etc. Therefore, with respect to cost, availability, and reactivity, NS can be considered superior to BSS. This is my second statement. So always remember that origin of life occurred in sea, and without it, life is unimaginable. With this statement, I conclude my session. Thank you so much. For more information, subscribe to my channel. Thank you.
Thank you so much, Dr. Khan. I do like your presentation a lot. As you can see, Dr. Neeraj, Dr. Kumar, Dr. Khan, he said acidosis is good, cost is less, evidence is not supporting. So do you have comment about what he's saying about normal saline? You have 2 minutes. Kumar.
I'm partially agreeing with Dr. Mohammed Saif, because he pointed very right, because in India, the most important aspect is I will accept the cost part, because these plasma light or balanced solution is very costly, and it's not so cheaper in compare with normal saline. And considering the affordability of the patient, these normal saline can be a better option. Yes, if you'll go by the evidences, I've shown all those latest randomized control trials, because these are the very larger group of trials done in n number of patients, in 10,000, 20,000 groups of patients. But even in a smaller change, that is the risk of that major adverse kidney event, that is very important, that is very crucial. But considering the facts about the osmolarity, what Dr. Khan has not elaborated about the osmolarity of normal saline, which is not closer to plasma in comparing, because it constitutes only two things, that is sodium and chloride. In a 308 is the concentration or osmolarity, which you can say. But in plasma light, the concentration is not to a range of 300, it is closer to 290, 95, which is more closer to physiological plasma solution. That's why I'm a bit in a favor of Dr. Saif, but not totally, because yes, I will accept one important thing, that what he highlighted about the reactivity also, because it is not compatible with the patients, because these ICU patients are on polypharmacy drugs. There are various drugs. So on these groups of patients, using those normal saline preferably will be more better than in comparison with the risk of your balanced salt solution. Yes.
So I can understand now you will use normal saline later on. Dr. Saif had convinced you to use it more than your balanced. So
yeah.
If Saif will finance me, definitely I will going to use BSS. Otherwise, I will go for non-slide.
No, another.
Dr. Khan,
I have,
Dr. Khan, you see, Dr. Kumar,
yeah,
he presented a lot of evidence. You can do a very rich evidence base which is supporting his balanced and the most physiological fluids we have to use, osmolarity, like that, buffering system. So what's your comment about what did he say? And the result?
see, may I say something? My slides were very few, but all were effective, because, as I said, it looks very physiological to use BSS, right? But it is all economic, what do you call, the health economics issue and pharmaceutical propaganda. It's all about that, because we know that we could not prove it in the recent trial, in the PLUS study, and all meta-analysis involving the 30 to 35,000 patients. So in the trials, all those physiological bases could not be proven. And as we can see in the latest trial, the rise in chloride level was only 3 millimole per liter, which is not going to affect the acidosis. And even if acidosis is occurring, it's not going to show you in the clinical outcome. There should be, for us, for clinician, the clinical outcome should matter the most. And that is where, I want to conclude my statement over here, that normal saline is better than PSS. or the mixture of BSS and normal saline is okay for me. So in our institute, we use both normal saline and ringalactin.
That
Thank
is
you so much,
best.
Dr. Kumar.
Yeah,
Yes,
that is
your
best.
comment,
That
Dr.
yeah, definitely I can go with normal line as well as BSS if we have option to choose between BSS and this NS, and if the hospital is providing that means on a lesser cost, then definitely we will go for, because cost is one of the major impact that is on our Indian setup, and it is very difficult to manage because all those patients are very economically weaker. So to write this BSS solution is not justified at all, and so at that place we can use, on the basis of cost, definitely we can go for normal slide.
I have a very nice comment from Dr. Riham. Yani she's trying actually to make all of us friends. She said we can use both. Why are not using both even with albumin 5%? Yani she's trying actually to make all our debates yani, friendly, talking about it, using albumin with balanced solution with cholesterol. Good suggestion even with isotonic, but still we are going with the specific indication. Will not comment about the albumin or whatever colors you are using now. I have a comment, Dr. Khan, he mentioned something very essential, which is traumatic brain injury, right? Of course, supporting
Yes.
his normal saline, right? The saline with such cases. You can try balanced solution with TBI, traumatic brain injury. Dr. Kumar. Can you hear me well?
I think.
Yeah, please, can you repeat the question? Yeah, please.
I'm asking a very valid point done by Dr. Khan, which is in traumatic brain injury, we have to use normal saline, right? So I'm asking, there is any place to use balanced solution for traumatic brain injury?
Any place to use balanced salt solution in? I'm not getting actually
TBI, traumatic brain injury.
Mitochondrial injuries.
Yeah, and brain injury.
Okay. Basically, yeah, I got that question. I have given that one references, and again the study was not a very done on very larger group of patient, in which they have used this balanced salt solution and they compared with this normal saline in a patient undergoing that severe injuries, including that traumatic brain injuries, and they have done initial resuscitation first 6 hours in these groups of patients, and what they found that the base excess and the base deficit, means the base deficit and the pH was more maintained in the patient receiving those balanced salt solution. But in traumatic brain injury patient, they suggested that these plasma light groups of patient, on comparing with normal saline has more better protection over these balanced salt solution.
Okay.
One study I got that.
Yes, great. Thank you so much. Let us have the opinion of our audience, right? We've now finished almost the debate. And before we started, actually, the question was 70% was using a normal saline and 30% was using balanced solution. Let us have the same question again. After debating, what is the most common fluid you will use in resuscitation of the patients and shock patient later on? Let me share with you, or I will launch the debate again. But again, don't consider the words. Just click on the number 1, 2, or 3. After debating, I want to see the percentage of the audience who will use normal saline or ringalactate or plasmalite in the future. You can just now vote either in the chat room or in the poll. Poll is now ready. Okay, in the chat. The balls are on the screen. You can just click 1, 2, or 3, A, B, or C. I want to see the percentage. Please reply now in the chat room. Oh. Most of them now, I think I have still almost 50% with the normal saline, 50% with plasmalite. So Dr. Kumar, he tried to convince 20% of the audience to use balanced solution versus normal saline. Let me share with you my perspective in just a few minutes, right? All of us agree we are using resuscitation fluid to save life. Before I will go with any fluids, I just want to give you what the pharmacodynamics ground of it. Simply, we are giving a fluid in this vein here, right? So whatever you are using a fluid, think about the tissues. This is your target, by the way, right? And of course, we have a lot of journey between the venous fluid infusion and the target of the fluids, like cardiac output, like responsiveness, like MAP, like microcirculation, and you have a lot of barriers between both of them. I have now a question for our colleagues, right? Would you consider hyperkalemic patient with lactated ringers? Should you infuse balanced solution for the patient hyperkalemic or have high lactate or hypercalcemic patient, Dr. Kumar? Do you have comment about that? You have patient hypercalcemia, you still give him some of the calcium in the lactated ringer, you give him some potassium in such patient. If you cannot hear me, let me comment. Really, I'm with lactated ringers, and you have to consider the amount of the potassium you are giving in lactated ringers is very, very minimal, like a drop in the pocket. So it will not be affected. The same like lactate, but hypercalcemia even, you can imagine the extracellular fluids, looks like almost 20 liters. How 4 milli equivalent of the potassium or calcium affecting those? Simply, significantly no effect either. Again, like as discussed in details by Dr. Kumar, acidosis could be good. Renal vasoconstriction have a debating about it. So still, actually, I have a concern for that. This is some methods of the truth of the both of them. I will just summarize what has been mentioned. Of course, the JAMA trial is supporting another split trial, which is against the SMART trials with the analysis, so meta-analysis with even with septic patient also it is query. So actually basic trial is against, plus trial is against, the meta-analysis no significant against, but clinically there is reduction in the mortality more than increasing in the mortality, especially with septic shock patient. This is assembly what they have mentioned. So my own perspective, last slides, I will continue with the balanced crystalloids, even the evidence not supporting, of course, away from traumatic brain injury and away from that. This is my own perspective, and everyone has their own perspective. I'd like to thank you so much. I do like my guest speaker. Thank you, Dr. Kumar and Dr. Khan. I really enjoyed with your. So, Prof, if you have any question in the audience,
thank you so
greatly
much.
welcome. Thank you so much, Prof.